Welcome all. Today we will see about hypokalemia. It is again one of the electrolyte abnormalities which we come across in admitted patients or in ICU patients. Contents of this presentation will be definition of hypokalemia, what are the etiologies, clinical features, ECG changes which we must know, what are the ECG changes of hypokalemia, what is the workup or approach to hypokalemia and how it is treated. By definition, a serum potassium level less than 3.5 milliequivalent per liter is called as hypokalemia. Etiology: first is due to poor intake, might be due to low dietary intake or administration of potassium-free IV fluids. Second is it might be due to non-renal loss like vomiting, diarrhea, excessive sweating, and large nasogastric aspiration. In this, urinary potassium excretion will be less than 20 milliequivalent per day. If it is renal loss, then urinary potassium excretion is more than 30 milliequivalent per day. And causes might be diuretics, osmotic diuresis, salt wasting nephropathies, or mineralocorticoid excess, Cushing's syndrome, steroid therapy, magnesium deficiency, amphotericin B Bartter syndrome. Fourth, redistribution or shift of potassium into cell, seen in metabolic alkalosis, insulin use, beta-2 agonists like salbutamol, and hypokalemic periodic paralysis. Clinical features of hypokalemia are fatigue, myalgia, muscular weakness of mostly of lower extremities. There will be constipation, paralytic ileus, and urinary retention. There might be paralysis of respiratory muscles which lead to hyperventilation, and there is a risk of dangerous arrhythmia like torsades de pointis. These are the ECG changes which are seen in hypokalemia, where you can see slightly prolonged PR interval, slightly peak P wave, then there is HT depression, a shallow T wave, and prominent U wave. These are the ECG changes of hypokalemia. So how we will approach to hypokalemia? We have to see for urinary potassium excretion. If it is more than 15 millimole per day, then we have to find out transtubular potassium gradient. If it is less than 2, it might be due to sodium wasting nephropathy, osmotic diuresis, or diuretic use. If it is more than 4, we have to check for acid-base test status. We have to check ABG. If there is metabolic alkalosis and hypertension is there, then it might be due to mineralocorticoid excess, or it might be due to Liddle syndrome. If this is Liddle syndrome, and if there is no hypertension, then might be due to vomiting, Bartter syndrome, diuretic abuse, or hypomagnesemia. Hypomagnesemia is another one of the cause of hypokalemia. If there is metallic acidosis, it can be due to diabetic ketoacidosis, primary proximal type 2 RTA, distal type 1 RTA, or amphotericin B. If urinary potassium excretion is less than 15 millimole per day, it will again assess acid-base status. In metabolic alkalosis can be due to remote diuretic use, vomiting, potassium loss via sweat. In metabolic acidosis, if there is metabolic acidosis, it can be due to lower GI loss, potassium loss. In this way, we can find out what is the cause of hypokalemia and treat accordingly. So what is the treatment? First, we should know what is the deficit of potassium. If the potassium is less than 1 milliequivalent per liter compared to normal, the deficit of 1 milliequivalent per liter, there is deficit of 200 to 400 milliequivalent of potassium. Oral potassium supplementation is a safer mode of correcting potassium. If potassium is between 3 to 3.5, recommended dose is 60 to 80 milliequivalent per day of oral potassium. That is 20 milliequivalent. 15 ml of potassium chloride contains 20 milliequivalent of potassium. So 15 ml you have to administer 3 to 4 times per day. If potassium is less than 2, you have to give 40 milliequivalent every 6 hourly. That is 30 ml every 6 hourly. Potassium chloride tablets contain 8 milliequivalent potassium per tablet. It is advised to dilute potassium chloride solution with glass of water to avoid gastric irritation. Side effects like esophageal or small bowel erosion in stricture can occur. IV potassium therapy, it is used in emergency situations in severe hypokalemia or when patient is unable to take orally. But these are the guidelines for IV potassium therapy. We have to monitor IV potassium infusion with ECG monitoring and frequent serum potassium estimation. Avoid IV potassium until urine output is established. Don't give more than 10 to 20 milliequivalent per hour. Don't give more than 40 milliequivalent in per liter of IV fluid. Don't give more than 240 milliequivalent per day. Never give injection potassium chloride directly intravenously because it can cause arrhythmia and sudden death. Avoid over-enthusiastic treatment. Hypokalemia is safer than hyperkalemia. Don't use 5% dextrose as diluent for potassium chloride because dextrose causes release of insulin, which will cause hypokalemia. Potassium concentration of 40 milliequivalent per liter can cause phlebitis. So do not use in peripheral veins, but it can be given in large veins through central line and femoral or subclavian vein. We have to know potassium. What are the potassium rich foods? These are fruit juices, coconut water, banana, dry fruits, chocolate, soups. And we must know the potassium concentration of IV fluids. 10 ml of 15% potassium chloride contains 1.5 gram potassium chloride, that is equal to 20 milliequivalent of potassium. Isolate M contains 35 milliequivalent per liter. Isolate P contains 20. G contains 17. E contains 10. While ringer lactate contains 4 milliequivalent per liter. So in case of potassium deficiency, we can use isolate M, which contains 35 milliequivalent per liter of potassium. In this way, we can use these fluids and to correct the potassium deficit. Thank you.